Hey, Martha. And my story with Mark Salzer. And, Mark told me I'm not supposed to give you a bunch of letters next to his name and all that. He just wants to be considered one of us. But he did found the Department of Rehabilitation and Sciences at the College of Public Health at Temple University. And so he's a professor there now, and also the director of the Temple University Collaborative on Community Inclusion of Individuals with Psychiatric Disabilities. And when we were talking about what we wanted for the webinar, we didn't want to repeat what's going to happen down in Florida. And I asked him, I'm always interested as a peer, what non-peers, why they get involved in the work that they do. And so that's where we're going with this. And we're thankful to Optum for providing financial assistance for this series. iNAPS is totally responsible for this. These are recorded and available on the iNAPS website for future viewing. As a participant in the webinar, your name, if you choose to provide it, may be included in the recording. If you prefer not to be identified by name, please sign into the webinar without using your name anonymously. So iNAPS, again, thanks you. Please mute your device and no video cameras, please. Also, as you know, background noise and participant video interfere with the presentation, so please be sure that both of these are off as shown. If you want to access the chat feature during the session, Mark will answer questions at the end. Please keep your audio muted throughout the webinar. Submit questions and comments during the webinar on the right side of your screen where it says chat. And in the chat, click the down arrow and select everyone. So any questions? And certificates are a member benefit. So if you are a member of iNAPS, you can send an email requesting a quiz for webinar number 38 to membership@inaops.org. After you complete a short quiz, you will receive a certificate. And membership is only $35 a year. It's a good deal. So I think at this time, without further ado, I'll turn it over to Dr. Mark Salzer.
Great. Thank you very much, Mike. And it's a pleasure to be here with everybody. And Martha, I think, let me try to see if you've got it turned over to me yet. There we go. Let me see. There we go. So I'm really pleased to be here with everybody today. I know for those of us on the East Coast, it's a little afternoon. For those of you elsewhere in the US, it is 9 or 10 o'clock in the morning. And I actually want to express a specific appreciation to my colleague Yako Aikawa, who I just saw is on. I'm very humbled that she has decided to be a part of this with us today. I think it is around 2 o'clock in the morning in Japan where she is. I might be a little off on that, but it's very early in the morning, and I'm humbled that she's here. She's a good friend and colleague of all of us, and I'm very pleased she's here. As Mike mentioned, I'll be talking about peer support and community inclusion and my story. And I guess I must say that in most ways, I would actually prefer hearing the stories of probably everybody who's a part of this webinar today, rather than me telling my story. Because as you'll soon find out, almost everything I know about peer support and community inclusion comes from people with lived experience. And if I take credit for anything over my career, it's that I do a good job of listening, or I try to do a good job of listening and learning from other people, especially people with lived experience. But I decided to tell my story because Mike recommended that I do so. And as I reflected on it, it occurred to me that I get asked frequently to tell my story about why I got interested in peer support, or why I got interested in community inclusion, or these kinds of things. And I don't think it's about me. I don't think it's because people want to know more about Mark Salzer. I think it's like what Mike said, people are just curious as to why researchers, why people get interested in these topics. And I hope that as part of my storytelling today about how I became interested, it will help us pursue some of my research colleagues and clinical colleagues to hopefully get them interested as well. So that's a little bit of background about where this came about. As Mike mentioned, I'm a professor at Temple University in the College of Public Health, and I also am the director of the Temple University Collaborative on Community Inclusion, which is a rehabilitation research and training center funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. It's important for me to mention that because the NIDLR funding, or my center funding, is what's paying for my presentation today. I'm not accepting, there's no honorarium or anything like that. So I am doing this as part of my, my center work. I also just wanted to make sure that I shared with you that I have no financial conflicts of interest to disclose associated with this presentation. There's nothing that I'll be talking about today where I am making a particular extra buck, or I'm not selling anything or anything like that. I do think it's important for me to be as transparent as possible on the type of funding that I do receive currently or within the past year, just so you are familiar with the kind of funding sources that I have. So that is on this slide right here. So I'd like to start my story by letting you know that in many ways, I have a traditional mental health background. I am a licensed clinical psychologist in the Commonwealth of Pennsylvania. I've worked in inpatient programs, locked acute psychiatric units, both in the Veterans Administration as well as in the public sector. I've been involved in pharmaceutical trials. I've been involved in biological studies, trying to attempt to understand factors associated with the experience of mental health issues. And I jokingly like to refer to myself as having psychiatry or being from psychiatry royal lineage. And the reason I use that term is that my grandfather, Harry Salzer, was a psychiatrist in Cincinnati and is credited with co-coining the term antidepressant with a colleague named Max Lurie. So if you look up antidepressant and Salzer, you'll see this connection. So sometimes I like to jokingly say, in some ways I've been destined for a career in the mental health area. But again, I'm just joking about it. I don't think there's anything genetic about these interests. But while I have this traditional background, as I mentioned before, I have really tried to listen to people and learn from people with lived experience, and it has definitely impacted my career over the years. I'm going to tell, during the course of the next 40 minutes or so, a couple of stories about how I became interested and introduced really to the concepts of community inclusion and community and peer support. I'll then go through my career and the people that I've been fortunate to meet over the years, especially people with lived experience, some people that you're hopefully familiar with, and talk a little bit about how these individuals influenced my thinking and the type of research that I do. And at the end of the presentation, I will be talking about some of my thoughts about the current state of peer support and community inclusion. And as Mike mentioned, I will be open for questions later on. So you can just put your questions in the chat box when you're ready. So this is a picture of the Hennepin County Medical Center in Minneapolis, Minnesota. I graduated from the University of Wisconsin in Madison in 1987 and worked for a year as a psychiatric tech on a locked acute unit, psychiatric unit here at this hospital. And it was within the first week of my working at this hospital that I had an experience that was incredibly eye-opening. What happened is there was a young woman, a little older than me at the time. She was probably 25 or 26, and she had been admitted for a suicide attempt. And as I was making my rounds the day after she had been admitted, I was walking through the unit to check to make sure people were there because it was a locked unit. And I came to her door and knocked on the door and didn't get an answer. I knocked on the door again, and there again was no answer. And finally, I knocked and entered her room because I needed to make sure that she was still there. And what happened is I saw her sitting on her bed, crying harder than I'd ever seen anybody cry in my life. And I didn't know what to do. I kind of froze, just like I'm freezing now a little bit. And all I could think about is, oh my goodness, she's suicidal, she's depressed, she wants to hurt herself. I need to call a doctor, I need to call a nurse, I need to do something to help address this young woman's needs. And instead, I somehow shuffled my feet and made it over to to a chair that was next to her bed, and I sat down. And as it turns out, that was probably the best thing that I could do, was to sit there and just listen to what she had to say. What I was expecting her to say were things like, "Mark, I'm so depressed, I'm suicidal, I want to kill myself, I don't want to live any longer." I was thinking about her as a patient, a person with a mental illness who needed the treatment that she was getting on the unit in order to decrease her depression and her suicidal ideation now and hopefully in the future. And instead, what she talked about were things that I could connect to as a person. She started saying things like, "Mark, I don't know how this hospitalization is going to affect my relationship with my husband. I recently got married and I'm concerned that he's not going to want to stay with me because I can't stay out of the hospital. Mark, I'm concerned about how what my parents are going to think about me, what my brothers and sisters are going to think because I can't stay out of the hospital and can't get over this depression." She said, "Mark, I'm worried about my job. I'm worried about losing my job if I stay here too long or if people find out that I have a mental health issue." She was worried about things that I could relate to as a person and a person at that stage of my life as well. And it really opened my eyes to the fact that people with mental health issues are people like anyone else, have the same hopes, dreams, and desires as anyone else, and that these disruptions in people's lives have as much of an impact on their physical, cognitive, and mental health as any underlying disease or genetic or biological process might. And I believe that this really got me started in thinking about community inclusion and the importance of community inclusion. So the next year, and I am trying to, there we go. The next year, I started graduate school at the University of Illinois in Champaign-Urbana. This is 1988. And I had the good fortune to work under the guidance of a gentleman named Julian Rappaport, who was a professor in the clinical psychology program there. And Julian is somebody that I'm really pleased to be able to let all of you know about, because he is one of the founding researchers who has looked at the concept of peer support, consumer-run services, self-help mutual aid groups. He's one of the wisest, smartest, and kindest individuals that I know. There was an organization called GROW, which was a 12-step based program for people with serious mental illnesses that started in Australia in the 1950s. And it was started by a Catholic priest named Con Keogh, who had been diagnosed with bipolar disorder. And Con Keogh came to Julian and other people at the University of Illinois and was interested in having a partnership or a collaboration with Julian, where Julian and graduate students at the University of Illinois could study the effectiveness of GROW and how GROW works. And the reason Con Keogh wanted to do this is because he believed that in order for GROW and peer support and self-help mutual aid groups to be successful in the United States, they needed to be evidence-based. So in the late 1980s, here was this brilliant individual, Con Keogh, who was talking about becoming an evidence-based practice. And these are concepts that all of us are familiar with now about being something that's important in the United States in order to get funding for these types of services. As part of my getting to know GROW, Julian asked me, first of all, to be a resource to GROW. I was asked to basically do anything that they asked me to do, help them write grant proposals, help them gather information, help them in any way I could as a first-year graduate student. And Julian also recommended that I get to know GROW. He said, Mark, why don't you start going to GROW meetings, 12-step meetings, and just get to know how this group operates and get to know them. What was interesting is at the time, again, I was being trained as a clinical psychologist. So during the daytime, I was sitting in classes learning about brain disorders and diagnostic criteria and providing psychotherapy and group therapy. And in fact, I had a faculty instructor who was very brilliant and very well known, who actually referred to self-help mutual aid groups as a group of 12, he used the word dunderheads, who can't even help themselves. How could they possibly help one another? So that's what I was exposed to in my professional training during the daytime in my courses. And I said, Julian, what am I supposed to do when I go to these groups? What am I supposed to do? And he said, Mark, relax. Just go be yourself. And that was the best advice anybody could have given me. I was able to go to the GROW groups and meet people as equals and sit and listen and observe how these meetings work and how peer support works. And what I discovered, contrary to my professional training at that point, is the most amazing help that could be delivered, peer support, and the help associated with peer support and non-professional support, and help that was delivered in a way and support that was delivered in a way that I would not be delivering as a non-peer professional in my career. So it was an amazing experience to get to know GROW and to be able to observe and get to know people as people again and learn about peer support by attending groups over the years. So those are two stories that really got me started in my work on community inclusion and peer support. Based on that work, especially my involvement with GROW, I became interested in how professionals, how non-peer professionals view self-help mutual aid groups, 12-step groups, double trouble groups, substance use groups, and I would say today their perceptions of peer support as well. I'm very interested in how professionals view peer support. So for my master's study that ended up getting published, I was involved in a survey of 1,100 mental health professionals in the state of Illinois. These were data collected in the 1980s, and we collected data from mental health professionals who worked in community mental health centers, private psychiatric hospitals, and state hospitals. And we gathered data from social workers, psychologists, nurses, psychiatrists, and other mental health professionals. And what I was interested in is basically to what extent are mental health professionals at that time referring people to self-help mutual aid groups? How helpful do they think self-help mutual aid groups are? And do they think that self-help mutual aid groups are as helpful as professionally led groups, or do they think they're less helpful than professionally led groups? So some of the data are presented here. The professionals, mental health professionals, overwhelmingly rated self-help groups as being helpful. So most people said, yes, these types of groups are helpful to people with lived experience. Most of the people and the agencies that people worked for referred individuals to self-help mutual aid groups, and more than 80% of the professionals that we surveyed referred people to self-help mutual aid groups. And again, this was at a time before one-to-one peer support or certified peer specialists, where most peer support was delivered in self-help mutual aid groups. And here is a graph of the data that we obtained. And this is actually comparing the beliefs of mental health professionals about the helpfulness, how helpful self-help groups are. And this is the green triangle on the bottom. The middle type of groups were how helpful these professionals viewed support groups. These were groups that were facilitated by professionals. And the top line, the red line, is how helpful professionals thought professionally led groups, or basically group therapy, professionally led group therapy was. And what we found is that even though mental health professionals found self-help mutual aid groups to be helpful, they consistently found them or viewed them as being less helpful than support groups and professionally led groups. That led us to coin the term professional centrism. Professional centrism is the idea that mental health professionals believe that the more a service is delivered by a non-peer professional, the more beneficial it will be to people who experience mental health issues. And the less involved mental health professionals are, the less helpful it will be. So that's the concept of professional centrism. Then I asked a question about whether or not the magnitude of this professional centrism, the more strongly you believe that professional involvement is associated with greater benefits to people with lived experience, the stronger that belief, will that influence your intentions to refer people to self-help mutual aid groups, generate funds to support these types of groups, and do other things to support self-help mutual aid groups. And the bottom line is we found that the stronger this professional centrism belief, the less likely mental health professionals were to refer people to the groups, help them get organized, and generate funds. And down here you can see where we published this, and I'd be happy to share any of this research that I talk about with you today. Please go ahead and send me an email and I can send it to you. So this is some of the early research that I did that really got me even more fired up about not only the importance of peer support, but why peer support might not get supported as much as it should be by non-peer professionals and by mental health systems. And it was really the notion of how helpful people believe them to be. At the same time, I was starting to get to know some of the consumer leaders who were in the field, and I started to become very interested in how I could use my non-peer professional voice to support the voice of mental health consumers, of people with lived experience. One of the first influences on me during this time was Judy Chamberlain. I had come across Judy Chamberlain's book called On Our Own. I think it was published in 1984 or 87. This is actually a picture of my copy of the book. I think I have a first edition version of the book, which I believe is very rare. And this is one of the first books that was published that talked about patient delivered or peer or consumer delivered alternatives to traditional or professionally delivered mental health services. And it was quite eye-opening for me as someone being trained as a mental health professional. Here you see a picture of Judy and a quote, one of my favorite quotes. There are real indignities and real problems when all facets of life are controlled. When to get up, to eat, to shower, and chemicals are put inside our bodies against our will. For me, Judy is one of those individuals who epitomizes the concept of consumer empowerment. At the time, I was writing an article primarily for non-peer professionals about the importance of consumer empowerment in mental health organizations. As I was writing this paper, I sent it to Judy and asked her to provide comments on it. And she graciously agreed to meet with me once in Boston when I was there for a conference. And as I have here, it was like meeting a hero. She was incredible and did many wonderful things for the consumer and peer movement. And I'm just very honored to have been able to meet her. Based on some of her comments, I made some changes and was able to publish that article in, I believe, 1997. Yeah, it's a long time ago. I can't keep track of everything. I wish I could see all your faces too, so I could see what makes sense. So after that, after my experience at the University of Illinois, I went to the Yale School of Medicine, where I did my clinical psychology internship and had the good fortune to work with Larry Davidson, who was a new faculty member at the time. And hopefully all of you or most of you know about Larry. He's one of the leading researchers in recovery and peer support research and has really been a wonderful colleague over the years. And I was fortunate to be able to work with Larry early on in both of our careers. I was also fortunate to be introduced to Pat Deegan in that year. Pat came to give a Grand Rounds talk, a big, very prestigious talk at the Yale School of Medicine. And Pat was talking about the concept of dignity of risk. Or the right of people to fail and make mistakes and learn from those mistakes. And I'd never heard about that concept before, and really am thankful to have heard from Pat. For those of you who are not familiar with Pat, she's developed intentional care and is a psychologist as well, a person with lived experience, and one of the wisest people, smartest, most innovative people, I think, who's out there. And I remember in particular Pat talking about the fact that Elizabeth Taylor, the famous actress, was allowed the opportunity to get married 8 times, including 3 times to the same person, Richard Burton. And she was allowed to do that. And nobody stopped her from making this bad decision, a seemingly bad decision, over and over again. And that's how she talked about dignity of risk. And that notion still sticks with me today. And I always give her credit when I talk about that example of dignity of risk. After finishing at the at Yale University, I worked briefly at Vanderbilt University in their School of Medicine. That is actually where I did some of my pharmaceutical research and other research somewhat briefly. before moving to the University of Pennsylvania, where I had the good fortune to work with Joseph Rogers. And for those of you who don't know Joseph, and I hope that's very few of you, he is one of the leading thinkers and doers in the consumer and peer movement for, I think, at least 4 decades, at least 40 years, still active, still out there doing things. And Joseph actually interviewed me for the position at the University of Pennsylvania. He was working at the Mental Health Association of Southeastern Pennsylvania, I think the executive director at the time, and thankfully he decided to hire me, or agreed that I should be hired to work with him on the Samsa-funded Consumer Operated Services Program study. This was a multi-site study funded by the Center for Mental Health Services in the late 90s and early 2000s. Gene Campbell was the lead principal, national principal investigator of this study. And this study is generated some good positive data about the outcomes of consumer-delivered services. I worked with Joseph and other individuals with lived experience at the Pennsylvania site, where we were studying a one-to-one peer support program for people with co-occurring issues, substance use and mental health issues, and worked with a wonderful person named Jeannie Whitecraft, who founded that program, which I think was one of the cutting-edge peer support programs that was available at the time. Up here on the upper right-hand side, you see a book that was published based on this Consumer Operated Service Program study. This book, called On Our Own Together, was edited by Sally Clay, who is also a very well-known advocate and leader in the peer support movement. In this book, we described the different types of peer support programs that were under study, and hopefully you have a chance to take a look at it, and because the type of programs we were looking at were incredible. So around this time, I was busy trying to seek additional funding for peer support research. I mentioned to you earlier the concept of professional centrism, that my non-peer mental health professional colleagues didn't always believe. They thought that peer support and consumer-delivered services were beneficial or helpful, but not as beneficial as professionally led services. I had submitted a number of grant proposals to try to look at peer support programs and peer support interventions, and had great difficulty at the time getting additional funding to increase the evidence base around peer support. My colleagues had equally challenging times getting research funding, and this is one of the challenges that we still face to a certain extent in work in this area. It's a little easier to get funding, but there's still challenges, and there are other types of challenges that I'll talk about in a few minutes. At the same time that I was pursuing peer support research, I also was interacting with a couple of other individuals who were talking about the importance of employment in the lives of people with long-term mental health issues. On the left-hand side, you see a picture of somebody named Irv Ruttman, who is credited as being one of the founders of Psychiatric Rehabilitation movement, and his mentee, somebody who Irv mentored over the years, named Rick Barron. And Rick is somebody that I've had the good fortune to work very closely with over the last 20 years. And with Irv and more with Rick, we started talking about issues related to community inclusion and the lives of people with mental health issues, not being focused on symptoms or diagnosis or those kinds of things, but instead being interested in employment issues. And what are the factors that affect employment and going to school and dating and parenting and these other things? And what types of interventions can enhance or increase the opportunities for people with mental health issues to be employed or do other things in the community? So I've got to credit Irv and Rick for some of my thinking in this area. So one of the things that Rick and I were doing at this time is we started rethinking the kinds of factors or reasons why unemployment rates for people with lived experience are so high. About 75 to 85% of people with significant mental health issues are unemployed. The traditional thought about why people are unemployed is because the thinking is it's because of their symptoms and their diagnosis and that their cognitive functioning. And we need to do something about symptoms and cognitive functioning and reduce the diagnosis. And when we do that, then people will be employed. Rick and I were at the same time trying to understand the work experiences of people with mental health issues and possibly the other types of factors that might affect people's lives. In one study, you can't read the title of this on the left, we actually discovered that most people with lived experience have work histories, and that people left jobs not necessarily because of mental health issues, but people left jobs for reasons like other people leave. They didn't like their bosses. They didn't get paid enough. They wanted another job. They didn't like their coworkers. The commute was too long. They moved. All of these are things that affect job tenure for anyone with or without a mental health issue. And that led us to write an article about looking at other reasons for unemployment other than symptoms and diagnosis and cognitive functioning. And that's the article, Accounting for Unemployment Among People with Mental Illnesses. So I'm very proud of this work, and it really introduced me or reinforced my sense that the experiences of people with who experience mental health issues is really more like anyone else or just like everyone else, rather than being different. People with mental health issues are people and shouldn't be seen so much as patients, or shouldn't be seen as patients. I did the same kind of work in the area of computers and use of computers. I was trying to get funding for, in the early 2000s, for research looking at computer use, computer training to increase employment outcomes for people with significant mental health issues. And the reviews that I got back from my colleagues, the grant reviews, were things like people with mental health issues don't want to use computers. They aren't interested in computers. They won't like computers. They won't want this training. So I had to do some research, and they were thinking that people would be paranoid of computers, or scared of computers, or their cognitive abilities wouldn't allow them to use computers. So that required me to do some research where basically I demonstrated that people with mental health issues are as likely to use computers as the general population and have the same attitudes and beliefs about computers as the general population. They weren't more scared or believed that computers were going to hurt them. They didn't have the attitudes and beliefs that some of my colleagues thought they had. So again, that was another example of just like everyone else. In 2003, I had the opportunity to apply for the first time for what's called a Rehabilitation Research and Training Center on community integration and participation of individuals with psychiatric disabilities. This was a new center funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. And it was a concept that at that time I was somewhat unfamiliar with. And the reason for that is that in the mental health community, we really spend more time talking about recovery and peer support. And we don't, at that time, we didn't talk as much about community integration and inclusion. There were a few people in our mental health community who were doing that, but it was very few. The people who did were people like Paul Carling and Judy Chamberlain and Pat Deegan and Joseph Rogers and some other people in the consumer movement knew about community integration and inclusion. The reason for that is community integration and inclusion are concepts that have a long history in the broader disability community, in the physical, sensory, and cognitive disability community. People who have hearing impairments, visual impairments, people who utilize chairs or scooters to get around. These communities were the ones who were talking about integration and inclusion, and the mental health community had moved off in their own direction and talked about recovery and peer support. Another concept that was familiar in the broader community is the independent living movement. And the independent living movement, again, was a big influence on some of the early consumer and peer movement leaders. And this movement talked a lot about peer support and advocacy, whereas in traditional mental health communities, we weren't really doing that. So I had the good fortune to apply for this center and learn these concepts pretty quickly, and was able to get funded. Along the way, I was also refining my sense about how we understand people with lived experience, and did one project early on in the movement to develop certified peer specialist training programs and hiring initiatives. In 2004, Pennsylvania funded some initiatives in this area and started training people with lived experience as certified peer specialists, and started hiring people as certified peer specialists in Montgomery County, Pennsylvania. And along with some peer colleagues, I was interested in understanding how hiring peers in the mental health system might change the perceptions of mental health providers, non-peer providers, about people with lived experience. So at this time, I asked a group of traditional providers, non-peer providers, and a few consumers and administrators and policy makers to write a story about a man named John who's diagnosed with schizophrenia, is 34 years old. Their story can be anything about how John thinks, feels, and behaves. Start your story with once upon a time. And the reason we did that is we felt that if we asked people to tell stories, we might get a better sense of how the individuals who wrote the stories view people with mental health issues. And we analyzed these stories and actually detected two basic story types. The first we called the John the Patient story. And these are stories that people wrote that focus on symptoms and loneliness and non-compliance and hospitalization and incarceration. And at the end of these stories, a positive ending for these stories would be maybe John living in his board and care, taking medications, and that was the end of his story. The alternative was something that we called the John the Person story, and that's the one on the right-hand side. The John the Person story didn't ignore John's mental health issues, but it talked about John's family and his relationship with his family, and John's hopes, dreams, and desires, and things that John wants to do with his life. And we felt that stories like somebody who tells a John the Person story is a supporter or a provider who is more likely to understand the importance of community inclusion and participation, and somebody who's better able to support somebody in pursuing community inclusion and participation. So that was another thing that I did that's had an impact on my work that also included people with lived experience. So I guess lastly, I want to talk briefly about a couple of my observations over the, 30 years that I have been involved with the consumer and peer movement and peer support. I think some of this is good news and some of it is evolving news, things where, at least from my perspective, we have some work to do. I would say that the first good news is that the early resistance to peer support services and consumer services, that consumer delivered services that I experienced and noticed has really changed into greater acceptance. As you know, most states now around the country are funding peer specialist services and training peer specialists and incorporating peer specialists in mental health services. My colleagues, led by Larry Davidson, wrote a review article talking about some of the evidence base behind peer support, and that is increasing or hopefully having an impact on the greater acceptance. I think some of the benefits, there's been a great penetration, as I mentioned before, of peer specialists in mental health services in the US and around the world, and the presence of peers in policy-making positions is really incredible, and quite frankly, something that 35 or 25 years ago, I would not have believed was possible. But I do have some concerns. 30 or 25 years ago, there were what were called standalone, independent, consumer-run or peer-run programs. These programs had a lot of independence. Advocacy was a primary function of these types of programs. The programs were led by peers. Hiring and firing decisions were made by peers. Job descriptions were made by peers. And my concern is that with the growth of certified peer specialists, policymakers and funders have decided to replace these standalone, independent, consumer-run programs with Medicaid reimbursed peer support services. And my concern is that some of the independence and advocacy that occurred at one point in time has decreased, and that it might be harder for current peer specialists to be able to advocate in the same way that they were able to before. Another concern that I have is about what peers are being asked to do, and whether or not what peers are doing is consistent with what I've learned over the years about a peer support ethos. And this has been an area that I've been involved with and tried to do research on for about the last 15 years, trying to understand what peers are doing, being asked to do, and how peer support is being implemented around the country. And my concerns are the peer roles are ill-defined, that the reciprocal nature of peer support, which underlies some of the value of peer support, is often lost in some of the roles that peers are asked to play. As I mentioned before, advocacy is sometimes not emphasized. And I'm concerned that non-peer professionals, my non-peer professional colleagues, are not really understanding what peer support is all about and haven't had the experience like I have of observing peer support and sitting in on self-help mutual aid groups and really trying to incorporate what the peer support ethos is all about. So those are some of my observations about the peer support movement over time and some of the challenges that I see heading into the future. My other concern from a research perspective is there is more research funding to look at peer support services, but some of the peer support that is being implemented, some of these grant proposals are being submitted by my colleagues who might not be as familiar with peer support and aren't being fully informed by people with lived experience as they define the roles of peer support interventions that they're studying. So I have concerns on the research angle as well. Some of my observations about community inclusion include after our center was born in 2003, there has been a dramatic spike in the number of research publications that use the term community integration and community inclusion. And I hope that our center played a little bit of role in that. And I'm really glad that community integration and inclusion is becoming better understood in our mental health community. I think there's increased interest in community inclusion and participation. We get a lot of requests for training and technical assistance across the United States and around the world. There are more initiatives aimed at promoting community integration and inclusion. People believe that it's important for people's lives and that community inclusion and participation is important for promoting recovery and wellness. But we also still have a lot more work to do to help people understand what community inclusion is really about and what it takes to make community inclusion and participation a reality. So I guess the last thing that I wanted to share with you is, I think Mike mentioned this, I will be one of the keynote speakers at the iNAPS conference in Orlando in December. I look forward to seeing all of you down there, and please come up and say hello to me and say you were at the webinar or not. And I'll be talking about these, about community inclusion in a little more depth. I'll be talking about what community inclusion is, why it's important, and why I think we should be considering it a medical necessity. I intentionally use that term because I want our non-peer provider colleagues to understand that promoting community inclusion and participation is just as important as taking medications, getting case management services, getting psychotherapy, getting any other type of symptom-focused intervention. Promoting community inclusion and participation is critically important. And I'll also talk about why I believe peers and peer specialists are particularly important for promoting community inclusion. I actually think the promotion of community inclusion and participation should be an essential role for peers and peer specialists. On the right-hand side here, you see a little diagram talking about the 11 fundamental concepts that define community inclusion. I'll be briefly talking about each of these fundamentals and where you can get more information about them at the conference as well. So with that, I will be open to your questions and comments. I'm excited to hear from you. So I can't see the chat box, Martha. I don't know if you and Mike are going to monitor that.
There hasn't been anyone in the chat, but I'd welcome people.
No, I have one right here, Martha.
All right.
Charles Swanson wants to know, how is a CPSS working with a few peers begin a program of community integration?
Yep, Charles, it's great to hear from you, and I hope to meet you in Orlando. And actually, your question is a very big question, and probably take days and days to answer how to make this happen. The first thing that I would recommend, actually, and I'll type this in the chat box as well, so other people can see this. We produced a document called Well Together. If you Google Well Together and my last name, Salzer, you'll be able to see this document and start learning about some of the concepts and fundamentals that underlie community inclusion and community integration. I also would say that I have been doing some work with the Copeland Center, with Matthew Federici and some of his colleagues at the Copeland Center. And we've been doing some training with peer specialists, talking about the role of peers in promoting community inclusion. So that could be another strategy. A third thing is, please send me an email, and I'd be happy to set up a time to talk with you further so I can support your efforts with your colleagues. So hopefully that's helpful.
Mark, so I have a question. First of all, that was amazing walkthrough of history there. I don't know how many people realize how amazing that was, but and it's very invigorating too, so thank you. So I was on a phone call with Medicaid North Carolina the other day, and they're transferring peer support from B3 services over to regular standalone service. But everything has to be determined by, a doctor has to approve it. There has to be medical necessity. And so how do we, of course, I wrote them a nice letter and sent them our principles of peer support. But so it's kind of like, it's, the word co-opting is big now. How do we work on that with Medicaid?
Yep. So I certainly support you and others who are pushing back on how peer support services are being rolled out and thought about all over the country. And I certainly support that. But I also, as I mentioned before, I have decided to use concepts of medical necessity as it relates to peer support because unfortunately that's easier, and I don't think it needs to co-opt how peer support is delivered. And basically I do it by encouraging peers to focus their efforts on promotion of community inclusion and participation. That part of their role in promoting recovery and wellness is supporting people in doing things in the community that they want to do, that provide meaning in their lives. And we have evidence that people who are with mental health issues, who are working, who are going to school, who are dating and parenting and involved in leisure recreation or spirituality, religion, all of those kinds of things of their choosing, so it's all self-determined, that people who are engaged in meaningful activities that they want to do, that is associated with better physical, cognitive, and mental health. And that is part of the definition of medical necessity. So as long as peers focus on those things, then they are providing medically necessary services. I'm not a big fan of the authorization process from a licensed or another licensed professional because peers are certified or in most states. But anyway, that's one way that I think non-peer providers who don't fully get peer support might be more accepting if we talk about peer support services that focus on inclusion and participation as a medical necessity.
Okay, and somebody asked how you can join iNAPS. All you have to do is go to our website and go under membership, and you can join for $35 a year, or if you're younger than me, you can get a lifetime membership for $350 and save a lot of money.
And I'm going to put up the screen again that shows how you can get a certificate of this, but please continue to ask questions if you would like.
Yeah, I lost my browser for a minute, so what email address do we use to contact Mark?
Yeah, it's in there. It's in the chat there.
Okay. Let's see. Any other questions, folks? You've got, thank you for this session. It was very helpful. Will you be giving more? I think I see you all over the place, Mark.
Well, I actually thought it was you guys. This is session iNAPS session number 38. So hopefully, if you're referring to iNAPS sessions. I'm sure that there'll be many more. As for me, I'm happy to support your efforts. Just send me an email. Let me know what I can do. Also sign up our center, the tucollaborative.org. Let me get that up there. You can sign up for our newsletter and our emails. We do offer webinars as well on community inclusion and participation.
And I'd like to recognize that Mark started out with Judy Chamberlain. Man, I never got to meet Judy, but I've read about her. I've read articles. I've read interviews with her. If you have not ever read anything about Judy Chamberlain, go online and look her up. Peer support was based on the concept of recovery, and community inclusion is one of those concepts. It's based on human rights and dignity of just being a whole person. And I'm just very thankful, Mark, that you've done this work. We appreciate it.
It's my pleasure, and I've been lucky. And again, I'll thank everyone who's a part of this webinar. Everything I know, I've learned from you or your peers, and I'm very fortunate.
I think it's 1 o'clock, folks. I want to thank everyone that's come on board. We have webinars every month. I'm sure we'll ask Mark to come back if we can drag him away from the Copeland Center. He mentioned Matthew. Matthew's one of our board members, is a wonderful person and has told me a lot of good things about Mark over the years. So we're very thankful again for this information. I hope you find it, we have a lot of issues in our lives, a lot of problems to overcome, and then you hear a presentation like this and I come away totally reinvigorated. So thanks again, Mark. Thanks everybody for joining us. And join iNAPS, $35. Yep,
join iNAPS. I've got to rejoin again too. Mine expired.
Right.
All right. Talk to you later. Bye, everybody.
Bye, everyone.